Good morning, everyone. So the topic for my presentation today is laparoscopic use of native tissue for pelvic floor repair. So hysterectomy, as we all know, globally remains the second most frequently performed gynecological surgery. One of the long-term risks associated with hysterectomy is the occurrence of pelvic organ prolapse. Some studies have shown that women after hysterectomy were 50% more likely to report symptoms of pelvic floor disorders. It has been hypothesized that the disruption of cardinal uterosacral ligament complex during hysterectomy decreases vaginal support. Therefore, adequate support for the vaginal apex is an essential component to reduce the incidence of post-hysterectomy wall prolapse. The American Association of Gynecological Laparoscopists also recommends apical fixation at the time of hysterectomy. So therefore, the interest to find out new ways to prevent the pelvic organ prolapse post-hysterectomy, the wall prolapse. So it will be a video presentation today. My case is, we had a patient who came to us, 68 years old, para 2 live 2, lady with previous 2 term vaginal deliveries. Last childbirth was 24 years back, presented with something coming out per vaginum and dragging sensation since last 3 years. She was a known case of hypertension, diabetes and dyslipidemia, and it was all controlled on medications. There is no history of difficult labor, chronic cough, urinary or bowel symptoms. On examination, there was a second-degree pelvic organ prolapse noted in the apical and posterior compartment and a first-degree prolapse noted in the anterior compartment. A per-vaginal examination revealed a senile-sized uterus, bilateral adnexa was normal. Patient underwent a total laparoscopic hysterectomy with bilateral salpingo-oophorectomy with pelvic floor repair. The procedure was uneventful and patient was discharged on day 3. Patient was kept on follow-up, histopathological report was normal, and there is no recurrence of relapse till 3 months post-op follow-up. So here we can see, to start with, ports have been placed. We usually do a supraumbilical port. So in the concept of native tissue repair, we have to do 2 methods, the McCall's cultoplasty, which we are doing routinely, even for an abdominal or vaginal surgery, and also we do a Moshkowitz repair. So the component of Moshkowitz repair is, we have to open the retroperitoneum, we have to make a fold of peritoneum on both the sides, and we'll use this peritoneum for Moshkowitz repair. So in this we can see in the right side, with the using harmonic, we have opened the retroperitoneum. Here is the ureter, which is nicely dissected. That the opening of peritoneum helps us in 2 ways. One, we get the peritoneum to cover over the vault so that the vault enterocele doesn't happen again. And secondly, it prevents the injury to ureter, because if we don't cut open the peritoneum and take a suture blindly, we might take up the ureter as well. So we can see on the right, the peritoneum is, we have started on the left now. So similar way, we'll open the peritoneum nicely, gently. It has to be done under experts, or by the experts only, because as we all know, retroperitoneum is something that's a lot of gynecologists are scared about or should be scared about. So start training with someone who is usually well versed with these procedures. Open the peritoneum. It's not usually very difficult. Go gently, and more importantly, don't use a cautery, monopolar or bipolar in either way. Harmonic helps in prevention of dissipation of energy, so therefore it's useful in such cases. Nicely we can see that the peritoneum is being separated. We have adequate amount of peritoneum on both sides. So usually doing this prior to the starting of procedures of hysterectomy helps, because once the uterus is gone, the anatomy it's difficult to make out. To find out the ovarian fossa, where to open the peritoneum. So usually what we do is, we open the peritoneum and we put a stay suture. So we can see here with ethibond, we have taken a stay suture, one on the one side of the peritoneum, one on the peritoneum of the POD, and one stay suture will put on the opposite side of the dissected peritoneum that we have made. And we leave the suture as it is so that it can be used at the time of closure for Moshkowitz repair. We can see the sutures we have taken from this side center, and that side. And just to check that if that will help in the closure, because Moshkowitz actually requires a purse string suture. We'll see in the subsequent video. It needs a purse string suture that needs to be taken from the peritoneum, and the POD peritoneum, and then taken from the anterior peritoneum, that is the bladder, that is UV fold, that also has to be included. So it should be a purse string that will close the pelvis, that will prevent the enterocele in future, and hence prevent the vault prolapse. So this is done. So we'll let the suture be, and then we'll start with the process of hysterectomy. The corneal structures will be coagulated. Here we are using Ligashow, the left corner structures we are dissecting. So harmonic makes the life easy for hysterectomy if we have. Now we are doing the colpotomy. We usually use a monopolar hook. We can see the ceramic plate. It prevents energy to go to the cervix and cause injury to the vaginal vault as well. Then we go ahead with doing the vault closure in the hysterectomy part. And we have to ensure that we take the uterosacral ligament while taking the vault. This helps in prevention of the vault prolapse, that is suspension of this. And this procedure, I think most of us, we are already doing, be it an abdominal hysterectomy, vaginal hysterectomy, or a laparoscopic hysterectomy for that matter. So that is, we all know, is one of the very key components of prevention of apical prolapse in future for the patient. So we have to ensure that the margins of the mucosa are not left. There are the normal concepts for TLH. That will avoid the bleeding or hematoma formation at the vault in the later time. So uterosacral ligaments are taken, the vault is closed. So we take that stay suture, the ethibond suture that we have taken at the stay suture at the earlier part. So we take that and we tie it to the vault, and then we'll tie it to the anterior peritoneum and put a knot. So that way helps in closure of the vault and prevents the enterocele. So post-hysterectomy, the most important part is to prevent enterocele, because that is what is going to cause the vault prolapse in future. The knot is tied. Ethibond usually takes more number of knots, so you need a good assistant as well for the procedure to help you in the procedures. So we can see here the peritoneum, that is the anterior UV fold. So now we are taking the purse string suture in the peritoneum. That will be the Moshkowitz repair. So as I said earlier, doing the dissection earlier, prior to the hysterectomy, helps us a lot. That way, it's already done. The anatomy is not distorted before doing all this, so it makes our life easy. And finally, the knot is cut, and we can see in the post-op picture, nicely the vault is closed by the peritoneum. Here, the UV fold has been, the peritoneum has been approximated. So hopefully, this patient won't have prolapse in the future as well. The post-op follow-up till 3 months has been good. So after hysterectomy, the vault suspension is a major intervention to prevent vault prolapse in future. The incidence of vault prolapse varies from 1 to 45%. So in Moshkowitz-McCall repair, the principle of these two procedures are combined. Combining the McCall's cultoplasty method and Moshkowitz method helps to prevent both vault prolapse and enterocele, and hence recurrence of prolapse. As we all know, McCall's cultoplasty, the uterosacrals are adhered to the, sutured along to the vault. So that is what is going to give the strength to the vault. Moshkowitz repair, as I told, a purse string suture has to be taken around the cul-de-sac to include the posterior vaginal wall, the right pelvic side wall, and the serous of the sigmoid and the left pelvic side wall. So a purse string will be taken to prevent enterocele. This was published in 2017, the McCall's cultoplasty during total laparoscopic hysterectomy, a randomized controlled trial, and they told that adding this step of McCall's cultoplasty, it doesn't significantly increase the operating time, estimated blood loss, and perioperative complication. Post-surgery also, sexual function does not suffer for the patient. And they concluded that McCall's cultoplasty is a feasible option. This was a systematic review, evaluated a lot of procedures that are done for vault suspension, and they found that McCall's cultoplasty, the old procedures, are the best procedures to prevent vault prolapse. So the conclusion of this will be the McCall's cultoplasty anyways we are all doing, and Moshkowitz repair we can also add in the procedure, so that it helps the patient helps us as well, and has a good outcomes and long follow-up for the patient. Thank you.